Hi everybody, this is Inting. So now I will proceed with my presentation. The first one I want to present is circadian rhythm sleep disorder. So basically, this disorder is caused by desynchronization between internal sleep-wake rhythms and also the light-darkness cycle. Okay, there are 6 subtypes of CRSD. Which is delay, advanced, irregular, non-24-hour sleep-wake type, and also jet lag and shift work disorder. So I will start with delay sleep phase type. This kind of disorder is actually a person sleep late and also wake up late. And this is more common seen in adolescents. And next is advanced sleep phase type. Which a person they sleep early, like 6 p.m. or 8 p.m. like that, and they also wake up early, like 3 a.m. or maybe 2 a.m. And this type is most often seen in the elderly, and the diagnosis is also accompanied by a familiar specifier. And next, irregular sleep type is actually disorganized cycle with variable sleep-wake period during a day. And typically, a person will have 3 or more sleep episodes during a day. And for the non-24-hour sleep-wake type, is actually an abnormal sleep-wake rhythm caused by a circadian clock that is not in phase with and cannot be entrained through the 24-hour light-dark cycle. And most often is seen in the blind individuals. Then is jet lag disorder. It actually happen when you travel to another country which has a different time. And next is shift work disorder. It's categorized by insomnia or excessive sleepiness resulting from a work schedule. And the general symptoms of CRSD are these 4: falling, staying asleep, waking up too early and not being able to go back to sleep, and also getting sleep but not feeling refreshed by it. Okay, for the risk factors of CRSD, there are a few, but I will just explain a few of it. Like for example, the genetic problem is actually got research show that there is some relation between genetic and CRSD. And for the shift work or time zone changes, it actually refers to jet lag disorder and also work shift disorder. For medical problems like Alzheimer or Parkinson's disease, they are having high risk to get this kind of sleep disorder is because their dopamine are usually low. Yeah. And then also have mental health problems, pregnancy or menopause, and also poor sleep hygiene are also the risk factors of CRSD. So for the diagnosis criteria for CRSD, there are 3, and a person must have these 3 criteria so that the person can be diagnosed as having CRSD disorder. The consequences of delayed sleep phase type. Okay, since we sleep late and wake up late, so of course we have no energy in the morning or afternoon, so that will affect our school performance and also job performance and may cause financial difficulty and also marital problems. For advanced sleep phase type, since we sleep very early and we wake up very early, so maybe it will cause us to have daytime sleepiness. We will feel like want to sleep during daytime. And for irregular sleep-wake type, the consequences is the person may have insomnia or maybe excessive daytime sleepiness. For jet lag disorder, it will disturb sleep, or a person may have impaired daytime function. And in addition is the gastrointestinal distress. This gastrointestinal distress is actually an illness like related to digestive system. And work shift disorder, a person may have depression, reduce their social and also family activities. Okay, for circadian rhythm sleep disorder, actually is like just now I mentioned, is related to our internal clock disorder. Like in our brain, there's a nucleus, and the nucleus will respond to the light, and that's why when there's a light, we will more easily to wake up, and when there's no light, we will more easily to get asleep. So for the intervention for this circadian rhythm sleep disorder, one of the intervention is bright light therapy, so that a person can reset rhythm by being around a bright light, like to let the person stay awake by using the bright light therapy. And next is sleep hygiene, which a person have to learn to change their bedtime routine or sleep environment. Chronotherapy is actually is more suitable for those who are having advanced sleep disorder, like they can slowly adjust their bedtime until it reach the time wanted. For example, at first they sleep at 6 p.m. and then they will slowly adjust to maybe 7 p.m., 8 p.m., and then lastly reach the time wanted, which is 10 p.m. And then next is the change of lifestyle. And lastly is medication, like melatonin. Then we are coming to non-rapid eye movement sleep arousal disorder. This kind of disorder is occur when the brain is partly in non-REM sleep and partly awake, which means we are partly asleep and partly awake. But however, we will have the ability to do some complex activities, like we go to eat, having sex, or maybe we do some shouting something without any conscious awareness. And mostly it's occurred in childhood, and more often in female during childhood and more often in male during adulthood. Okay, the first type of NREM sleep arousal disorder is confusion arousal. It occurs when the person wakes up in a confused stage. And then it's sleep terrors. It involves a person appear to be awake, but is actually asleep, experiencing profound panic, which might involve hitting or running around and inconsolability. Next is sleepwalking. It involves the person sitting up or getting out of bed and walking around when they are asleep. And sexsomnia. This is sleep sex. It involves a person who is sleeping, engaging in sexual act, such as masturbation, groping, or sexual intercourse. But this is different from having an erotic dream, because erotic dream is just dream, but sleep sex is they actually do it. And lastly is sleep-related eating disorder. Is a specialized form of NREM sleep arousal disorder, and it involves recurrent episodes of involuntary eating or drinking during sleep. General symptoms of NREM sleep arousal disorder are partially asleep and partially awake, and then it occurs for lasting 1 to 10 minutes but can last longer, and it usually happens during the first third of the night, and they will feeling confused or disoriented if awakened during an episode, and those persons will have no memory of their dream or sleep behavior in the morning. And for the risk factors, okay, it's more high risk in persons who are having sleep deprivation, which is they are more easily to awake when they are sleeping, And when they are having medical or psychiatric illness, have pain or emotional stress, shift work, and they are taking medications, and their family history, there are someone who have this disorder, will increase the risk of ones to have this disorder. And however, the cause of sleep sex is not really known. Okay, the diagnosis criteria for sleepwalking and sleep terror is different. Sleepwalking is a repeated episode of rising from bed during sleep and walking about. While sleepwalking, the person has a blank, staring face, is relatively unresponsive to the effort of others to communicate with him or her, and can be awakened only with great difficulty. While for sleep terrors, is a recurrent episode of abrupt terror arousal from sleep, usually beginning with a panicky scream. There's intense fear and sign of automatic arousal such as mydriasis, tachycardia, rapid breathing, and sweating during each episode. There's relative unresponsiveness to efforts of others to comfort the individual during the episodes. Consequences for confused arousal are disturbing for the parents or bed partners, and sleepwalking and sleep terror may cause injuries to the sleeper or their bed partner. For sleep sex, a person may feel guilt or shame, and if the sleeper engage in sexsomnia with an unwilling person, there can be legal ramification as well. For sleep-related eating disorder, okay, a person may have injury or maybe have hypercholesterolemia, hypoglycemia, dental caries, and weight gain resulting from recurrent sleep-related binge eating of high-calorie food. The interventions of NREM sleep arousal disorder are differentiated into two categories. First is non-violent behavior, and the next is violent behavior. For non-violent behavior, a person may try good sleep health practice such as getting enough sleep and avoiding alcohol use, and make safer environment by removing harmful objects. And for those who are having violent behavior, they can consult non-pharmacological therapies for long-term management by having psychotherapies, progressive relaxation, or maybe hypnosis. And they will also can have some pharmacotherapy with benzodiazepines, typically clonazepam, tricyclic antidepressants, typically imipramine, or SSRI, typically paroxetine, may provide temporary relief. Then we have rapid eye movement sleep behavior disorder. Okay, the difference between this disorder and the non-REM sleep arousal disorder is RBD is in deep sleep kind of stage, which is REM sleep, while for non-REM sleep arousal disorder, uh, the disorder is occur when the person is partially awake and partially asleep. Okay, this is the difference. And this kind RBD patient, they do not experience muscle atonia during REM sleep, which means when they are dreaming, they can still move their hand, move their leg, unlike the usual people. Like usual people, when they sleep, they are in a deep sleep, they cannot move their muscle. Okay, so they may have multiple episodes during a night, like occur a few times, and maybe only experience every week or longer. And this disorder is actually very rare, and is however most common in men over the age of 50, but it may begin at any age. Those who are having RBD usually will act out their dreams, include the events that trigger wild emotion, while motion with physical movement. Like for example, they may grabbing or leaping out of bed and crawling. And also they may have some loud talking, swearing, laughing, and shouting. And they will remember the things that are associated with RBD episode, including the nightmares in which the patient tried to defend himself from an attacker. While the risk factors are the presence of neurological disorder like Parkinson's disease and multiple system atrophy, and alcohol consumption or withdrawal, strokes, brain tumors, sleep deprivation, or medication use. The diagnosis criteria for RBD is recurrent episode of arousal during sleep associated with vocalization and/or complex motor behaviors like physical movement that arise during rapid eye movement REM sleep, like which a person are mostly in a dream. And they may cause injury for both the patient and also the bed partner. So for the interventions that can be used for those RBD is switch in medication if it's caused by medication, abstaining from alcohol if it's caused by alcohol consumption, and also medication, or put a protective device over the subject's hands, or keep sleep environment safer. After that is nightmare disorder. This disorder is generally occur during REM sleep, similar with RBD, and it often result in the person waking up, which a person will wake up after this disorder, and mostly children experience them compared to adult, and it can increase excessive daytime sleepiness. A person who have nightmare disorder will have frequently and persist over time nightmares, and it will routinely disrupt their sleep and cause one's feeling fear of going to sleep and cause daytime behavior problems or difficulty functioning. Those who are having medical disorder are in high risk of having this disorder, or for those who are having psychiatric disorders such as depression and anxiety, or maybe those who are taking medication including antihypertensive, antidepressant, and also antihistamine. Diagnosis criteria for those who are having nightmare disorder is recurrent episode of extremely dysphoric and well-remembered dreams that usually involve effort to avoid threats to survival or security or physical integrity. So the consequences for those who are having nightmare disorder, they may have excessive daytime sleepiness, thereby impacting their health. And usually, nightmare disorders can be symptoms of other conditions such as migraine and PTSD, and it may also cause depression and anxiety among those who are already experiencing depression and also anxiety. The interventions for nightmare disorders are cognitive behavioral therapy, and eye movement desensitization and reprocessing. This is also one of the psychotherapy, and also hypnosis. Okay, next is restless leg syndrome. Okay, from the name, actually all of you can guess what kind of syndrome it is, which is a person will keep moving their leg. Okay, this syndrome is also called Wheeler-Ekper's disease, will cause unpleasant or uncomfortable sensation in the leg and an irresistible urge to move them. It may begin at any age. Well, however, women like us are more likely to have it than men. and usually those who are severely affected are middle-aged or older. Okay, the symptoms of this restless leg syndrome is the persons will have irresistible urge to move, they will feel relief with the movement, and they will have worsening of symptoms in the evening or night, and they will have nighttime leg twitching, and also they have sensations that begin after rest, which means when they stop moving their leg, they will have that kind of sensation like itching, throbbing, pulling, or itching. So this causes them have the irresistible urge to move their leg. The risk factors for restless leg syndrome are mostly related to medical or illness. Like, okay, for first is the biological factor, which is genetic, and then is iron deficiency. Next, dysfunction in brain that control movement, and then those who are having end-stage renal disease and hemodialysis are in high risk of having this disorder. For those who are taking medicines, they may trigger this RLS, also in a high risk of having this RLS. For pregnancy, usually pregnancy, women may have this kind of syndrome, but usually it's in the last trimester, and research found that it's usually recover after delivery in about the period of 1 month. And the use of alcohol, nicotine, and caffeine may also increase the risk of having this disorder. And neuropathy also cause a person having high risk to having this disorder too. The diagnosis criteria for this RLS. Okay, a person will have strong and often overwhelming need or urge to move the leg. That is often associated with abnormal, unpleasant, and uncomfortable sensation. And when they are resting or inactive, the urge to move will getting worse. And the urge to move the leg is at least temporarily and partially or totally relieved by the movement. And usually it starts at the evening or night. And last but not least, the important part, the above 4 features are not due to any medical or behavioral condition. And to diagnose this disease, you may conduct a physical, a neurological exam, blood test, or may refer to a sleep specialist. A person who has IRS may have poor sleep, distress, impaired functioning, excessive daytime sleepiness, and their quality of life will become lower due to chronic conditions, including diabetes, depression, or hypertension. And for the interventions part, they may change their lifestyle, or for those who are having low normal blood tests, they can take more iron, or maybe the person who are having RLS can take more medications such as anti-seizure drug, the dopaminagic agent. Okay, the second last is substance or medication-induced sleep disorder. Like from the name, you can know that usually this kind of sleep disorder is caused by someone take some substance or take some medication. Oftenly, it happens on child and may happen on adolescent or early adulthood because of the use of illicit substance. And older individuals also had higher risk because they are usually the group that take medications. Okay, those who are having this usually have several problems with sleep, and this issue started during or soon after using too much of a substance or when they trying to withdraw, and the issues are not related to another kind of sleep disorder. And these issues cause distress in a person's life or trouble in functioning in work and in other part in their life. Of course, those age group who are high in substance abuse or dependence on medication use are in high risk of having this kind of sleep disorder. And the vulnerable individuals who easily take substance or medication are also in high risk too. So for the diagnosis criteria is first a prominent and severe disturbance in sleep, and it's actually occur after substance intoxication or after withdrawal from a medication, and the involved substance or medication is capable of producing the severe disturbance in sleep. And the disturbance is not better explained by a sleep disorder that is not substance or medication induced. So for the interventions, just like the factors caused by substance and medication, right? So the intervention is stopping related medication or maybe dealing with the symptoms of having stopped taking it. Lastly is the other specified and unspecified sleep disorder. Other specified insomnia disorder is referred to the disorder which do not meet the full criteria for insomnia disorder or any of the disorder in the sleep-wake disorder diagnosis class. For example, brief insomnia disorder, which the duration is less than 3 months, or restricted to non-restorative sleep, which predominant complaint is non-restorative sleep unaccompanied by other sleep symptoms such as difficulty falling asleep or remain asleep. And next is unspecified insomnia disorder. It does not fulfill the criteria of insomnia disorder or any of the disorder in the sleep-wake disorder diagnosis class. And however, there is insufficient information to make a more specific diagnosis. And then for the other specified hypersomnolence disorder, it refers to the disorder who do not meet the full criteria for hypersomnolence disorder or any of the disorder in the sleep-wake disorder diagnosis class. For example, brief duration hypersomnolence or Klein-Levin syndrome. Then is unspecified hypersomnolence disorder. It do not fulfill the criteria of hypersomnolence disorder or any of the disorder in the sleep-wake disorder diagnosis class. And there's no sufficient information to make a more specific diagnosis through it. And next is other specified sleep-wake disorder. It refers to the disorder who do not meet the full criteria for any of the disorder in the sleep-wake disorder diagnosis class or any specified sleep-wake disorder. For example, repeated arousal during REM without polysomnography or history of Parkinson's disease of other sonoclinopathy. And next is unspecified sleep-wake disorder. It do not fulfill the full criteria for any of the disorder in the sleep-wake disorder diagnosis class and any specified sleep-wake disorder. And however, there is insufficient information to make a more specific diagnosis. Well, now for this part, I'm going to explain the relation between brain and also sleep disorder. The area of the brain involved control of sleep and wakefulness is actually the brainstem and also hypothalamus, like a few of friends mentioned before. For those who are promote arousal, is the brainstem and hypothalamus, who include tuberomammillary nucleus. They promote wakefulness by sending arousal signals, for example, orexin or histamine, to the cerebral cortex. And then for the promote sleep part, and there's a neurons in a part of the hypothalamus called the ventrolateral preoptic nucleus (VLPO). The signals from VLPO neurons inhibit activity in arousal promoting centers so that it promotes sleep, just like what shown in the pictures. And I want to mention SCN, suprachiasmatic nucleus, is actually meant to control the transition between sleep and wakefulness. It actually have relation to the circadian rhythm sleep disorder. It's actually a body's internal biological clock who regulate the timing of dozens of different internal functions by responding to the day-night cycle, which is the light, like I explained before at the circadian part. And the SCN promote wakefulness by producing alerting signals that offset sleep drive and promote sleep by turning off alerting signals. There are a lot of neurotransmitters which are related to the sleep disorder part, but I will just pick 3 of it. So the first one is orexin, which also called as hypocristin. Is linked to arousal and wakefulness and almost exclusively produced in the hypothalamus, and it was found the most common type of narcolepsy is caused by a loss of orexin through the destruction of orexin producing cell. So for melatonin, is usually high at night, which is during sleep, and low during the day, during wakefulness, and is regulated by the suprachiasmatic nucleus I mentioned just now of the hypothalamus, which react to the amount of light in the environment. And melatonin dysfunction is frequently related to deviation in amplitude phasing and coupling of circadian rhythm. A common symptom of insufficient melatonin signaling is sleep disturbance. Okay, next we move to dopamine. It involves in numerous behavioral and psychological processes which operate on the basis of wakefulness. Dysregulation of the striatal and nigrostriatal dopamine are related to Parkinson's disease, and usually, patients with PD have been reported to suffer from several sleep disorders including insomnia, EDS, REM sleep behavior disorder. So that means there's a relation between the low dopamine and also sleep disorders. Okay, for the last part, I would like to present the case study in Malaysia which is related to insomnia. The client of this case study is Puan Suraya. She was a 40 years old lady, worked as a school teacher, while her issue is having difficulty falling asleep. Puan Suraya having difficulty to sleep well for more than 2 years. Usually, she went to bed at 10 p.m. but is unable to sleep until 1 a.m. Even she sleeps, she will experience about 3 to 5 awakening every night, and each time she will require 30 minutes to fall asleep again. And other than that, she experiences daytime fatigue and is unable to concentrate in her work. Well, need to mention that Puan Suraya, she do not take naps during the day. She also do not snore and no usual limb movement during sleep. Generally, her health is in a good condition. Well, however, she mentioned that she involved in a stressful family property dispute, and it was prior to onset of her sleep difficulty. As bedtime approached, she will become very tense and worries. Well, she did not take any sleeping pills and have no symptom of depression, no marital conflict. Well, the surprise thing is she sleeps well when on a vacation or when she's sleeping in relative house. Puan Suraya has been diagnosed having psychophysiological insomnia, sometimes referred to as learned insomnia or behavioral insomnia. It usually follows a stressful life event, so the patient may not always be able to recall the event. The precipitating event resolved, but the insomnia that was experienced during the period of psychosocial stress remains and take a chronic course. She has learned sleep-preventing association where bedtime and home sleep environment result in agitation, arousal, and increased muscle tone. She has formed an association between the home bedroom environment and also not sleeping. So, as bedtime approaches, she anticipates another sleepless night that increases tension and arousal. She also experienced paroxysmal improvement in sleep when outside their usual sleep environment or not carrying out bedtime routines. Her learned behaviors seem to have a dominant role in the insomnia, and no other associated medical or psychiatric disease to explain the insomnia. Thus, she is diagnosed as psychophysiological insomnia. The treatment given to Puan Suraya are behavioral therapy, stimulus control therapy, and also cognitive behavioral therapy. For behavioral therapy, Puan Suraya will be instructed to maintain a sleep diary, maintaining good sleep hygiene, and also stress management such as muscle relaxation techniques. For stimulus control therapy, therapists will help the patient, which is Puan Suraya, learn to reassociate bedtime and the sleep environment with sleeping and correct learn maladaptive behavior that disrupts sleep. Well, usually it will take several weeks to learn and provide clinical benefit. For CBT, is aimed at identifying and changing maladaptive sleep habits, dysfunctional beliefs, and unrealistic expectations that the patient has about her sleep and that may perpetuate her insomnia. CBT aims to replace this view with more adaptive substitute. The reassurance and discussion on this issue clarifying misperception can be therapeutic. That's all our presentation. Thank you for listening. Thank you very much. Sorry for my broken English. Clap, clap.